Today's episode shout-out goes out to our listeners in Japan. Thank you for listening to the 1pm podcast.
Hello everyone, welcome to another episode of the First Principles of Medicine podcast. Today we'll be discussing a general and practical approach to rash, which should help you with your med school written exams and OSCEs, as well as providing a solid framework for evaluating and managing rash as an intern on the wards and in ED. My name is Jason. I'm a final year medical student at the University of Western Australia. Today I'm joined by two of my med school colleagues, Maria, say hi.
Hiya.
And Joe.
Hello.
We're also incredibly lucky to have on Dr Matthew Ghodsian, who's a first-year dermatology reg at Sir Charles Gairdner Hospital. Matt completed basic physician training before starting derm, so he's well accomplished in both internal and external medicine. Thanks for joining us, Matt.
Thanks very much for having me on. Just before we go on, I just want to give a quick caveat in that anything that I say that's smart today is a direct reflection of my mentors, and anything that I say that is stupid is a direct responsibility of my own and no one else. So.
That's very beautiful, Matt.
Matt, before we do begin, I just had one question. In your professional opinion, who of us has the best skin?
Tricky.
Well, I'm actually freaking out.
That's why I've asked it.
I'll say that there's a combination skin. We'll go with this, and yeah, I won't say, but
That's very diplomatic.
Yeah.
All right. Cool. So the plan for today's episode is as follows. First, we'll start with a discussion of the derm exam and how to describe our findings. Having a good framework for describing what we're looking at is incredibly important. It helps us narrow our differential as well as consult our derm colleagues effectively. Next, we'll look at the normal basic anatomy and function of the skin, which is really important as it helps us understand how the pathophysiology links to the presentation of diseases. Then we'll go through a rash history with an emphasis on red flags, so that even if we don't get the exact diagnosis, we can still be safe doctors and know when to ask for help. Following that, we'll go through a possible diagnostic framework you may want to use while assessing a patient. And lastly, we'll go through some illness scripts of some common classical and important conditions. But before we do any of that, Matt, what exactly is a rash?
I think historically, a rash, people think of a rash as a bumpy, red, itchy phenomena of the skin. But I think we're taught to think about a rash as just a colour or a textural change, and not necessarily the classic macular papular or erythematous. And kind of an extension from that, I guess, is a rash can also be a nodule or a papule. It doesn't have to be a fixed one area. It can be a widespread thing, it can be a local thing. So I think any skin change whatsoever makes you think that this is not a normal process and there's something going on in the skin.
Cool. Now, since rash is such a broad term, it was actually quite difficult to find literature on its epidemiology. But I think it would be fair to say that the lifetime prevalence is basically 100%. Everyone gets a rash, right? To put it into perspective, the University of Sydney collected data on presentations to general practice between 1998 and 2016 in the Beach dataset. For reference, the number one most commonly managed problem in the GP setting was high blood pressure, making up about 5.7% of visits. I don't know if you guys want to have a guess at what percent of GP visits were for rashes. Joe, maybe?
I think maybe one a day, one every 2 days.
I asked for a percent.
Yeah, I'm doing the maths. So
Okay.
2 every day. Oh, sorry, one every day. 5%.
Okay, Maria?
Well, you said the number one was 5.7%,
Mm-hmm.
and you said that the lifetime incidence is about 100% or prevalent.
Well, that was me riffing, but yeah.
Okay, fair enough. I'm going to go, what did you say, Joe?
I said 5.
You said 5?
Yeah.
Oh,
All right,
okay,
it's
I'll
not
go
that serious.
4.5.
4.5. Okay, well, you both overestimated, I think. 2.5%,
Oh.
right? Which is still quite a lot
Yeah,
when
it's
you
fair
when you
amount.
put it into perspective. So upper respiratory tract infections, 3.3%. Rash at 2.5% is more common than diabetes at 2.3 and high cholesterol at 2.1. So it's incredibly common. It's worth being on top of. You also see it in pretty much every setting, right? So GP, ED, inpatient wards, family gatherings, if you're particularly unlucky. So, good to be across it. Joe, I think it makes sense to start with discussing the derm exam and some common rash terms and terminology, as that's really the most important part of our assessment. Do you want to take us through how to examine the skin?
Okay, so let's go through actually describing the rash, because it's a pretty important skill for interns and medical students to be able to work on. It's not necessarily recognising and knowing how to treat every single different type of rash, but come up with some sort of description and a format that they can deliver that in a referral to a dermatologist. And it's probably not going to be of much use to go through all the different words and phrases that dermatologists use, because there's lots of them, and some of them are very specific. And also to go through it without some sort of visual aid is going to be pretty hard. So what I think is a good idea to do is go check out some resource like your lectures or DermNet or YouTube and look at some pictures of rashes and how they're described. However, just quickly, we can go through the method of how you could describe a rash. So the things that are important to comment on are the distribution, the configuration, the colour, the morphology, and any secondary features. And it's all pretty intuitive if you think about it for a sec. If you just stop and look at a rash for a second and think to yourself, what are all the different ways I could describe this rash? So the distribution, is it generalised? Is it covering most of the body area? Or maybe is it just confined to an anatomical region like just the hands? Is it just on flexural surfaces like eczema is? Or maybe on extensor surfaces, so on your elbows like psoriasis is? And then the configuration, is it just one discrete lesion, or is it multiple lesions that are confluent, or are they coalescing? And then colour is obvious. Is it erythematous, so is it red, or is it hypo or hyperpigmented? Morphology is what shape the lesions are. And this one's probably one of the more important ones. And again, I'll reiterate that you want to look at some visual aids for each of these. But the key ones you'd expect to differentiate are probably macules, papules, nodules, patches, and plaques. So if we just go through them quickly, so macules and patches are flat. So if you're running your hand over it and you had your eyes closed, you wouldn't be able to tell the rashes there. And a macule is a small lesion, a flat area of altered colour that's less than a centimetre in diameter. And if it's greater than that, if it's a larger area, then we would call that a patch. And now if you run your hands over it and you can feel something there, it's got a raised surface, it's a raised palpable lesion. Similar to a macule, if it's a small one, less than a centimetre in diameter, we call that a papule. And then if it's greater than that, if it's a large one, we would call that a nodule. That's often if it's a solid, raised, sort of isolated, well-circumscribed lesion. If it's more like a patch, so like an area of skin that happens to have a raised edge, but kind of more like a flat lesion, we would call that a plaque. And then maybe the other two that are worth noting are if they're fluid filled, so similar to a papule, but if that was filled with fluid, then we would call that a vesicle. And then if it's small, so less than a centimetre, and then if it's a large, greater than a centimetre and similar to what, most people I guess would call a blister, is often called a bulla. Then we could also describe any secondary features that the lesion might have. So is it scaling? Is it crusting? Is it ulcerated? Or are there fissures or excoriation or scratch marks with it as well?
So now we have a solid understanding of how to examine a rash and what things to note. Can you talk to us a little bit about the basic skin anatomy?
Yeah, so again, this is one of those things that it's a lot easier to have a look at an anatomy textbook and the different layers and a diagram. But assuming you have seen all that before, then if we think about our three key layers of the skin, and I think a good way to why it's good to have this understanding and this first principles of medicine is after this, when we understand what type of cells are in each cell layer and what they do, we can start to understand why the different dermatology diseases present the way they do. So if you think about the epidermis, starting from the top to the bottom, epidermis on top is a complex brick wall made of cells called keratinocytes, which produce a protein called keratin. The epidermis also contains pigment cells, which make the pigment in your skin called melanocytes, so they produce melanin. There's Langerhans cells, which present antigens to the immune system, and Merkel cells, which have sensory function. So the epidermis itself is made up of several layers from top to bottom. I'll just go through the key ones. So the striatum corneum, multiple layers of anucleic, so no nucleus, dead keratinocytes that are eventually shed, loosened and fallen off. The stratum granulosum, so there's cells that are granulated, they produce keratohyalin, which is involved in keratin adhesion and skin moisturization. And then at the very bottom, the stratum basale, which is a single layer of melanocytes, keratinocytes, stem cells, and Merkel cells. So there's 5 layers in total there, so the corneum, the lucidum, the granulosum, the spinosum, and basal. But I just went through the key ones there and the key cells to remember. The layer below that is the dermis. So that's mainly connective tissue that supports the epidermis, provides nutrients, protecting it. So the epidermis, you'll notice there was no blood vessels or anything in there. The dermis is what provides nutrients and protection to the epidermis. The papillary dermis is the upper portion beneath the epidermis, and the lower portion is the reticular dermis, comprised of multiple different structures in tissue, such as collagen, so a structural protein that makes up the bulk of the dermis, nerves, so sensory and autonomic fibers with distinct nerve endings for touch, heat, cold, pressure and pain, and blood vessels. There's arterioles, capillaries, venules and veins all throughout the dermis. The lymphatic system, erectopili muscles that are attached to hair follicles, and then cellular infiltrations. So immune cells around blood vessels are recruited in great numbers to heal wounds, and many skin diseases are characterised by the specific patterns these cells take when they react to an infection or to a wound. And then, so we've got epidermis, dermis, and then the subcutaneous tissue at the very bottom. And it's made up of adipose cells or fat cells, and they're surrounded by connective tissue, blood vessels, and nerves.
Mm-hmm. And then you mentioned a bit earlier how having an understanding of the anatomy kind of helps us understand how and why diseases present the way they do. Do you want to talk to that a little bit?
Yeah, I think the most important takeaway from this is probably having an understanding of how to describe different lesions, and especially key ones. But I guess a bit of a deeper thing is then, like you said, taking that anatomy and linking it to the pathophysiology. And so from what we've just sort of described, thinking about what cells are where, if we think about the epidermis first, so we have no blood vessels, it's just 90% keratinocytes. So anucleic keratinocytes that shed in the stratum corneum, or granular cells that produce keratohyalin and that aid in cell moisturization in the stratum granulosum, or melanocytes in the stratum basale. Our lesions are going to be maybe scaly, or they might be hyperkeratotic and pigment changes. So just listing a few. So if we think about stratum corneum, scaling lesions, we think of psoriasis or fungal infections. If we think about the stratum granulosum, so associated with that cellular moisturization and dryness, then we have diseases like ichthyosis. And then the stratum basale, if we think about that bottom layer that contains the melanocytes, then things like nevus or vitiligo as well. Mm-hmm. Then if we move down, we think about the dermis. So in this layer, it's mainly collagen, there's blood vessels, and like I said, immune cells around these blood vessels that come in to fight infection and give many dermatoses their specific patterns. It's also separated from the epidermis by the basement membrane, so the disease process can also affect the epidermis if it invades, and you can get epidermal findings too. So examples here would see urticarial wheals. So wheals are raised plaque-like lesions that are edematous that you often see in diseases like anaphylaxis or urticarial, And the reason is that's edema infiltrating, and that's coming from those lymphatics and blood vessels that are within those, the dermal layer. Blue nevi, this one's a bit more interesting. So that's melanocytes that are located within the dermis, and the reason they appear blue is because they're deeper, the scattering of the shorter wavelength of light compared to the more superficial brown nevi. And then I guess the important takeaway from this layer as well is thinking about those blood vessels within the dermal layer. So erythema indicating increased blood in the capillaries, so vasodilation, as opposed to purpura, which is blood leaking out from those vessels themselves. When we have erythema, the reason it's going to be a blanching rash, so if you were to place a glass against it, press against it, and that rash disappears, is because that blood is still within the blood vessels that have just vasodilated, as opposed to purpura, where the blood has actually leaked from the blood vessels into that dermal layer or into the subepidermal layer. And so pressing something against it isn't going to push that blood from the vessels, it's stuck within that layer. Mm-hmm. And then the final layer is subcutis. So adipose cells. So in general, it's going to be smooth lesions, potentially raised if they're edematous or inflamed. An example here is erythema nodosum, which is a paniculitis, so inflammation of the fat, and they're firm tender nodules with erythema. Mm-hmm. Yeah?
So I guess just to summarize that then, like kind of the epidermal findings we're thinking of, scale, hyperkeratosis, potentially pigment changes, whereas dermal, and things that are strictly dermal or affecting the subcutis tend to be smooth because they don't have epidermal involvement, and they can be raised if there's edema, and that's because those layers have blood vessels, but the epidermis doesn't.
That's exactly right, yeah.
Sure.
So if we put that into practice a little bit, do either of you guys, or Matt, do you know what Nikolsky sign is?
Yeah, so classically, Nikolsky 1, or the Nikolsky that everyone knows, is that there's some epidermal destruction or loss. And yeah, gentle rubbing or friction causes shearing of the top layer of the epidermis, thereby it desquamates or it falls off. It's like the classic pemphigus or SJS. But there's also this phenomenon of Nikolsky 2 or Aspo-Hansen sign, where you have a blister and the skin around it is really tense and kind of vulnerable. And you press on the skin around the blister and the blister actually extends underneath the skin. So you cause extension of the blister rather than shearing of the top layer. And that is also a demonstration that the epidermal junction has been lost. And so just if you don't have shearing doesn't mean you can't have SJS or pemphigus.
So that's epidermal junction.
No, it's desmosomes in between the epidermis.
Granulosum and corneum.
That's right. It's all in the top layer. Yeah. But you're getting fluid extension. So I look for that every time I see a patient with SJS, or I think they have SJS, and they've got a tense blister. I press around the blister and see if I can shift the fluid around their skin. Things like bullous pemphigoid or any other kind of bulle type situation where the blister is underneath the epidermis in the epidermal-dermal junction, you press on the blister, it doesn't move. It's quite fixed. But in these kind of epidermal conditions like SJS, it moves.
Right.
And Matt, so leading on from that discussion about the anatomy and how it relates to the underlying pathophysiology of a rash, how often is it that you're looking at a rash and like using these first principles to think about what it might be versus just straight up sort of pattern recognition of seeing things in books and going, that's what it is?
I think for me, and perhaps for everyone who's junior like me, going to first principles is something I do every single day. Every single patient I see, I think about first principles. I think for my bosses, it's a very different situation where a lot of the time that I'm sure they still use first principles, but it's intuitive to them. But I think when you're learning, it's really important to think about the morphology and think, what diseases do I know that fit this morphology? And that's the first question. Because in derm, a lot of it is actually terminology. So diseases are bundled around terminology. And so if you hear something is papulosquamous and scaly and you scratch it and it bleeds and it's on the scalp and ears, you think psoriasis. If something is called flat-topped and kind of superficial and violaceous, you're thinking, and it cobnerizes, you're thinking lichen planus. So there's a lot of terminology that if you can actually see a rash, think about the morphology and bring out those words, then actually helps you with a diagnosis. The second thing I think, an extension from this, is you use what spoke about earlier about where is this occurring? Is it in the top layer? Is it in the middle of the skin, or is it deeper? And further to that, you also have to think, is this all primary change? Is this the primary dermopathy, or are we seeing secondary changes? So often you'll see annular lesions that are red and, maybe scaly. It could be tinea, it could be urticaria. But then there's all these excoriations around. There might be some crusting around. Then you think, could this be eczema because it's crusting? You have to think back and go, what was the first thing I saw and how did this evolve? Is this just urticaria? Someone has scratched it. It's now been infiltrated with staph and the secondary pitigo. Or is this actually a kind of bacterial thing from the start? So going back to first principles and thinking, what's the morphology? Where is it? What does it look like? And are there any primary or secondary features? Is absolutely fundamental to knowing what's going on.
Nice.
Thanks, Matt. Maria, let's move away from anatomy for a second, because frankly, I'm bored of it. And let's talk about physiology. So why do we actually have skin, apart from not looking like freaks?
Fair enough. Well, so apart from not looking like freaks, the skin actually has a whole bunch of really important sort of functions and has a really important role in terms of our overall physiology. So as you alluded to, Jason, the skin serves as a physical protective barrier, first and foremost. It's also really important in other aspects of homeostasis, so things like thermoregulation, water balance, so it helps keep water in the body. It's important for metabolism, so think vitamin D synthesis. It allows us to feel things, so it has a role in sensation. And then that kind of leads into its last, I guess, major function, which is obviously like having a psychosexual role to play, I guess. And these are really important functions, and I guess the importance of them is mostly highlighted when the skin is unable to perform these functions. So if someone has like a severe dermatological condition, let's say SJS, the skin isn't able to do the things that it's supposed to do. Patients can actually become really unwell. And it's kind of analogous to things like decompensated heart failure, where for whatever reason the heart isn't able to do what it needs to do, and the patient, like I said, becomes quite unwell. So in patients with SJS, they lose a lot of fluid and they lose all these electrolytes because the skin isn't able to keep water in. They also are unable to regulate their body temperature, so they can end up profoundly hypothermic. And then, the immune functions. Oh, that's what I forgot to mention before, actually. The skin is really important in terms of the immune system, so being a barrier to infection, but also sensing and relaying effector immune responses. The skin's not able to do that in SJS, for instance, so patients can end up with these really horrible infections.
Mm-hmm.
So, Matt, I just have a question. I've not done my dermatology placement yet, so I'm not really sure. When you have these really sort of like severe derm presentations, to what extent does a dermatologist get involved? Do you guys take over care, or are you guys just a consult service? How does it work in the hospital?
Yeah, I think the first thing to say is that everyone should try and get a derm term. I'm saddened that you haven't had one. It's the best specialty.
It's upcoming.
Yeah. We do get very involved, and there's multiple reasons for that. Generally speaking, if a patient has SJS, it's not a single organ disease, as you know. So, oftentimes the first thing to think about, and it's not just SJS, I'd extend this to anyone with a large pustular kind of erosive dermopathy, even things like erythroderma where the whole body's involved. I'd still call that a sort of skin failure in some ways. We get involved, for diagnosis, because that is often the most important thing, because we're talking either, antibacterials versus heavy-duty immunosuppression. So getting us involved early when you think there's red flags or something is evolving to something that is a bit more dangerous and other organs involved, very important. The second thing is that sometimes you miss the boat with a biopsy if you've already started treatment. So that's another reason why we like to get involved really, really early. And I think the third thing is then, once you've decided treatment, sometimes we're really nice to wash your hands, but I think the reality is that there's so much more that's going to occur. These patients are going to be at risk of infection and fluid loss. They're going to be, once we've put some immunological drugs on them, they can develop secondary immunological problems. Sometimes we give them TNF, they develop psoriasis. We give them, hydroxychloroquine, they get something else. It's kind of this ongoing management. And so that's why we stay involved throughout their whole admission. The other thing is, for some conditions like SJS, there's a SJS protocol. Really good to read the statewide protocol, and you'll see that there's dressing care, there's eye and mouth care, there's genital care. So, we think about skin is the ones we can see, but oftentimes it's other areas as well. And then the final kind of part of all of this is, are they going to have any long-term problems from their skin, like scarring, things like that. So, we definitely get really involved.
Yeah, because I was going to ask, do you guys then follow them up after they've left the hospital? Like, is it an ongoing follow-up from derm?
Yeah, absolutely. Really important that we follow them up and see how the skin's going 30 days out, 60, 90 days out. And also, if we think that there was a drug trigger, we almost always will get immunology involved to see whether we can prove that with HLA testing.
Oh, yeah, cool.
Really good to see how they're tracking.
Maria, let's say you're standing outside the door of your next OSCE station, and the only thing it says on the trigger is that you're an intern on ED, big tertiary hospital, and your next patient presents with a rash. What are you going to ask?
So I'm going to gather my thoughts and go in calmly.
Always.
And I'm going to start, as always, with a history of the presenting complaint. And I think this is something that Matt will touch on, but one of the things that I guess I've done in real life whenever I've taken a history from a patient with a rash is, provided the location of the rash allows, I actually just ask them to show me the rash so I can have a look at it whilst we're discussing. And I found in the past that patients actually find it quite useful because they can point to specific things of the rash and really sort of use it as a tool to describe what it is that they've been experiencing. So I look at the rash if I can whilst taking the history. And I think one of the most important things to understand is the time course of the rash. So I'd start by saying, when did this rash come on? How long has it been there for? Has it been there consistently? Or does it come and go? Has it changed in any way? So has it progressed? And that progression can be a change in morphology, like we were talking about earlier, or it could be a change in distribution or severity, intensity, etc. I'd ask if the patient has noticed any aggravating or mitigating factors, things that make it better or worse. Specifically, if they've tried any medications or topical treatments that have made the rash better, because I think that that's quite useful because it gives you an understanding of the pathophysiology and potentially the underlying etiology of the rash. So say a patient comes in with a rash and say, oh, I took an antihistamine and it got better. So then you start thinking more down the lines of like allergy and atopy, for instance. And then once I've understood the time course of the rash, I then want to ask about associated symptoms. And I think of these in terms of the symptoms of the rash and then sort of systemic associated symptoms. So with the rash, I'd ask, has it been itchy? Is it painful? And if it is painful, what does that pain feel like? Has it been bleeding or has it been oozing? And if it's oozing, what is it oozing? Is it pus or serous fluid, stuff like that? And then I'd also want to ask, like I said, some systemic questions. Hopefully at this point in the OSCE, I've got an idea of what's going on, or at least I have some differentials, so I can target my questions to that. And I think a really easy example of that would be if someone came in with a non-blanching petechial rash, I'd specifically want to ask my OSCE patient, have you noticed a fever, a headache, photophobia or pain with the light, etc. So that's where I would go with my history in the OSCE, I reckon.
Yeah, cool. I think as you touched on towards the end there, it's really worth emphasising how important it is to try and characterise the rash further. So like what constellation of symptoms is that patient presenting with? What are their demographics as well? For example, is this rash in the context of a new drug? Is this rash plus a fever in a return traveller? Is it rash plus, a headache in an unvaccinated teenager? That sort of thing.
Yeah.
So now we've got a clearer picture of the presenting complaint. How do you further narrow down your differential?
So I think a good thing to do at this point would be to take an exposure history, because aside from really niche autoimmune or maybe genetic kind of rashes, in theory, a new rash in a patient should have a trigger that we, again, in theory, should be able to identify. So taking a really thorough exposure history, I think, is something that I value. And there are 4 main groups of exposures that we can think about, and I have a whole list here of things that go under each category. The first group would be indoor exposures. So that would include things like soaps, makeup, jewellery, watches, pets at home, things like that. Sick contacts, so have they been around others who have been sick, plus or minus a rash, etc. And then obviously sexual exposures, I think, would fall under this category. The next would be outdoor exposures, so always asking patients have they travelled recently, and specifically where they've travelled and what they did on their travels as well. Other outdoor exposures would be, just any sort of contact with nature. Have they been camping? Have they been hiking? Have they been swimming in lakes? Have they noticed any bites on their skin that could potentially be from an insect, for instance, things like that. The third group of exposures would be occupational exposures, and I've got some examples here. So for instance, if you've got a fisherman, that's kind of important for maybe like Vibrio infections and rashes associated with that. If your patient is a farmer, that can maybe take you down the path of Q fever potentially. So always asking, what do you do for work? How long have you done that for? And sort of characterising that. And then the last thing that's probably amongst some of the most important line of questioning would be to ask about things that have been ingested or injected. So a big one would be prescribed drugs. So have they started any new medications? Have there been changes to dosages of medications? Things like that. Always asking about illicit drugs and substances, obviously doing so in a manner that's appropriate and sensitive, but it's really important to get that information from a patient. And then other things you can think of are things like vaccines, tattoos, and foods. Have they eaten somewhere differently? Things like that. And then I guess the final thing is that if you can't identify a specific trigger, then that makes other aspects of the history a bit more important, I guess. So you'd need to take a full comprehensive history and social history, focusing on points like autoimmunity, atopy, allergies, systemic disease, immunosuppression, either personally or in the family as well.
All right, thanks for that, Mia. Matt, back to you. So there's obviously quite a large list of risk factors and exposures there, and you wouldn't necessarily ask each of those every single time you take a rash history. So maybe from like a Australian or even like a Southwest Australian derm perspective, is there anything that you think should be higher up in your list and things that we should be asking for? Like, for example, rheumatic fever or things like that?
Yeah, that's a really good question. I'm going to tiptoe around the answer. And the reason for that is because derm is this really interesting career, let's say, where you work a bit backwards to the rest of medicine. In medicine, someone comes with chest pain, you spend the majority of your time on history, and by the end of your history, you've almost certainly got a diagnosis. And then you confirm your diagnosis with these extra tests and biochemical values. But I think in derm, a lot of the time it's the other way around, where you look at the patient, you think about all those things you spoke about earlier, the morphology, whereabouts in the skin, how did this happen, and based on the pattern that you see is how you direct your history. And so, for example, if you see someone and they've got a rash over their chest, eyes and orbit and arms in these photo-distributed areas, then you go hunting about, autoimmune things and photo exposure, sun exposure and things. So all your questions are going to be directed towards that. I think sometimes it's hard to just ask someone a million questions about their rash. The things I would say, though, that almost always there's some drug involved somewhere. And so it's really, I think irrespective of what you see, it's always important to think, could this be a drug reaction? And the thing that's really important with that is that people sometimes think, oh no, I hear this all the time where people say, oh, I haven't had any new drugs recently. But actually what we find is that a lot of drug rashes, the median time of onset of the rash is many, many months. In fact, sometimes a year or two. And in some conditions, you can see it 15, 10 years later. So it's really important to know all of their drugs and actually take them all into consideration. The other thing to think about is, particularly in Australia, I think in Western countries, is over-the-counter stuff. We're drilled this all the time in medical school, always ask, do they take things? But people actually are really afraid to tell you that they take things. I'll give you two good examples. We've had 2 cases this week of carver-induced breast. Yeah, and it's only after talking to them and you find out that they had something else in their family, a grievance or something that's occurred, they were feeling low, and then from there they ended up taking this tablet which is meant to be an anxiolytic, and then now they've got this rash. Unless you spend that time with the patient and actually work out what they're kind of taking, you'll miss that whole diagnosis. So I think that's probably one real good thing to say. The other thing is that we're also so lucky in this country that we have so many different jobs and lots of occupational stuff in WA. So things that sometimes we forget about are air allergens. So for example, you're a baker, there's flour and all these other things in the air. We have a lot of big mining industry in there. It's really hot, so we see a lot of resistant tinea. As you said, we see a lot of kind of scabies and rheumatic fever. So I think, honing a history to where they're from and also thinking about what other environmental exposure is really, really important. But a lot of the time, the history is entirely guided by what you see.
Thanks. And another question. Are there any red flags to keep in mind that should prompt us as interns to refer urgently to dermatology?
Yeah, definitely. I think this is a really good way to think about it in an inpatient setting as well as, does this patient need to be seen urgently? I think the red flags in 2 different ways. I think, is something bad happening now? And then, is something bad going to happen later? When I discharge this patient? That's generally how I frame it. Is something bad happening now? I think about, are we in a dangerous territory with systemic involvement? So do they have fevers, lymphadenopathy, LFT or renal derangement? Are they symptomatically unwell with chest pain or whatever else? Nausea, vomiting, abdominal pain that's unexplained, cyclical fevers. This type of syndrome that's accompanied, and therefore is the rash collateral damage? Is this like a secondary phenomenon? The body's just unhappy and you've got this rash, or is the rash a primary thing like an SJS where you've had a drug, hypersensitivity, your skin's falling off, and then everything else crumbles? So I think that's probably the really main urgent thing. Specifically, I look for blisters, I look for pustules, vesicles. I look to see how widespread a rash is. So erythroderma is classically 90% body surface involvement or more. And the reason why that's important is because when you have such inflamed skin, you then have such a huge amount of fluid electrolyte loss. So then they're a sitting duck for things like dehydration and hypokalemia and things. And then from there, you also think, could they actually go into circulatory failure and everything else? So that's kind of are bad things happening now? And then one other thing that people don't check for is mucosal involvement. It's really easy to miss if you're just using an iPhone torch, but if you use like a medical lamp, especially if you're at Charlie's or Royal Perth, one of the other hospitals where sometimes the lighting isn't as good, you really need to have a good look in their mouth. And I think if you see something with blisters, always check the genitalia because you will miss something. And then they're really critical because if you have a young person who is, for example, or I guess even old, but sometimes we see obviously more ramifications. If you have a young person with penile vaginal stricturing, it's a real disaster for their future. So always look. So that's the bad stuff. And then I think, okay, what is the potential for something bad to happen? Well, if they've had a drug recently and now they've got a rash and it's evolving, I think they need a little bit more monitoring. Or if their LFTs are slightly going off, they need a bit more monitoring. Or if they've recently been immunosuppressed, now they've got a rash and it's all coming up, again, more monitoring. So I think that's a good way to think about red flags.
Mm-hmm. Awesome, thanks for that. Great. So given that rash is such a huge topic and that as med students and junior doctors, we aren't often very confident in it, I thought it would be best to keep our diagnostic framework quite broad. I think if you're listening from Australia, you've heard of the Mertag model. And that just in short is basically, what are my probability diagnoses? What's most common? What are my serious diagnoses? Things you don't want to miss. What are some pitfalls? Things that are often missed. What are masquerades? So things that can present in a billion different ways. And is the patient trying to tell me something else? So we'll go through each of those maybe. In terms of probability diagnosis, it's important to say that this will differ by the setting. If you're in GP versus you're on the ward versus ICU, and by demographics. So is this a child, an adult, an old person? But in general, the most common diagnoses you'll see, or the most common rashes you'll see, are things like inflammatory skin disorders, dermatitis, psoriasis, acne, rosacea, common infections, staph, strep, shingles, chickenpox, that sort of thing. Then there's serious disorders, and you want to be thinking about these every single time. Even though they're rare, you never want to miss them, right? And these are things that can cause either that acute skin failure that Maria talked about earlier, or just otherwise might indicate severe underlying systemic disease. So those are your scars or severe cutaneous adverse reactions, which are, those really bad rashes associated with drugs. Bad infections like meningococcus, neck fash, your blistering skin diseases. So your pemphigus vulgaris, like Matt talked about, your staph scalded skin syndrome. And then there's a couple other miscellaneous ones, but that are important to think about. So erythroderma, which as we said is any condition that causes involvement of more than 90% of the skin. And often that's associated with drugs, hematological malignancies like lymphoma and leukemia, psoriasis and eczema. Anaphylaxis, obviously, if you see someone who's urticaria, they obviously, maybe start developing a stridor. You have to think about that. And there's also maybe a bit less important, but something you can think about are neutrophilic dermatoses. So if anyone's heard of sweet syndrome, basically presents with a fever and tender erythematous papules and plaques, usually or most classically on the dorsum of the hands.
Why is it called sweet syndrome?
Named after. I don't think it's because it's good. I think it's because it's named after Mr. or Mrs. Sweet.
Oh, right, okay.
And that's it. That's an emergency or a serious disorder because it's associated with hematological malignancies.
Oh, okay, right, yeah.
Cool. Then you've got your pitfalls or things often missed. I couldn't really think of many things to include here because I feel like that's everything in dermatology. Like if you crack open a massive derm textbook, there's like 1,000 disorders. So at that point, it's kind of the realm of the dermatologist. You've thought of everything you could. Refer. Then in terms of masquerades, in terms of the Mertag model, those are classically diabetes, drugs, anemia, thyroid disorders, spinal cord. You can kind of work those into here. So like diabetes can present with skin findings, acanthosis nigricans, necrobiosis lipoidica. Drugs, obviously, we talked about that. That's a huge thing in derm. Anemia, I guess they can be pale, but that's not really a rash. Thyroid disorders can absolutely affect the skin. So you can get dry, cracked skin. You can get myxoid changes, thyroid acropathy, I think it is, and so on, right? And other masquerades to think about, just your classical infections. So syphilis can present as a billion different rashes, HIV, atypical mycobacterium, and different fungal infections. Obviously, you're not jumping to those straight away, but if you've investigated a rash, you can't figure out what's going on, these are things to think about. Lastly, is the patient trying to tell me something else? Really, you're just thinking about like, what's the psychological factors going on here? So, a teenager with acne, are there mental health things you need to address, and so on? Why are they coming to me today? If you're struggling to think of diagnoses, the other thing you can do is just refer back to your surgical sieve. So vitamin C, D, E. Cool. Maria, do you want to help our listeners consolidate all of those derm terms that Joe was talking about earlier by maybe going through some common rash illness scripts?
Sure, I'd love to. So I'm going to describe a rash. And at home, if you're listening, just try to pause the video, maybe have a think about what it could be. I'll give you a second or so, and then we'll give the answer. So the first clinical vignette is a 10-year-old boy with a background of hay fever who presents to you with an intensely pruritic, erythematous, excoriated, and lichenified rash made up of papules and vesicles, which is distributed bilaterally on the flexural surfaces with associated scale. God, that was a lot of words.
But that's important, right?
Yeah, they're buzzwords. They're definitely buzzwords.
It's buzzwords and it's derm language.
Yeah, no, they're definitely buzzwords.
Jason, I'll take this one. So if we look at some of the key features here, so we've got a young boy, a history of atopy, so that hay fever. It's pruritic, so it's itchy. We know that because we're being told, but also through the excoriations and the lichenified means that it's likely they've been scratching or rubbing at it. Distributed bilaterally on fleshy surfaces, and the scale as well, we know that's associated with the epidermis. And so I think the most likely thing here is that it's atopic dermatitis.
Correct. So we'll move on then to the second clinical vignette. So the second example is a 25-year-old female with a well-defined, symmetrical, pink and silvery scaly plaques on the extensor surfaces as well as her trunk, and there's also some associated nail changes.
So I think that's psoriasis.
You're correct. It is psoriasis.
Yeah.
Good job. Okay. The next clinical vignette, a 30-year-old woman with confluent erythematous plaques across her upper cheeks and bridge of her nose, sparing of the nasolabial folds, as well as a scaly rash on her trunk and upper arms. What do we think this one could be?
Well, this is, I mean, there's not a huge description in the, well, there is a little bit about the type of rash, but I guess it's hard to use first principles here and say what's actually happening. I mean, obviously there's a lot of things happening, but I think this is one of those ones in an illness script that you have to sort of use a bit of that pattern recognition as well. And one of those buzzwords being, you know, a rash of the face with sparing of the nasolabial folds, the age of the woman as well. I'd potentially say SLE.
Yeah, this one's a SLE, yeah. And yeah, the sparing of the nasolabial folds and like the sort of young to middle-aged female, they're sort of like triggers or buzzwords, I guess.
But I guess that's a malar rash as well.
Yeah, a malar rash is the fancy word for it. Yep. Okay, so moving on. A 5-year-old child with preceding malaise, sore throat and coryza now presents with crops of pruritic erythematous macules, papules, vesicles and pustules, predominantly on the trunk, with some spreading onto the limbs and face. Some of the lesions appear crusted. What do we think this one is?
Well, I've had this one before, and that's chickenpox.
Yeah, that's right. Have you had chickenpox, Joe?
Yeah.
Yeah, I think most people have had
I
it,
think
right?
Joe's from the time when they used to have chickenpox parties.
No, stop. Did you actually?
No, I wasn't invited.
Then the last sort of example I have here is an irritable 5-year-old child with a fever, cough, and conjunctivitis, presents with a non-itchy erythematous papular rash, convalescing into macules, which started on the face and has since spread to the trunk and limbs. There are associated small ulcerations on the mucosa within the mouth. I avoided saying the word buccal because I don't know how to say it. Buccal or buccal?
I think it's buccal.
I thought it was buccal.
Oh.
Anyways.
Yeah, that was a really long-winded way of saying morbilliform, wasn't it, Maria? But that's good,
Correct.
right? Because
it is. Morbilliform, yeah,
we're
that's
always told, even
Yep.
if you literally have measles in front of you, don't call it maculopapular because, you know, you'll be laughed at by the dermatologist on call.
I think if it's measles, I think it's allowed.
You think so?
Yeah.
You think so?
Yeah.
Is it the only one that you reckon maculopapular rash is okay to say?
Maybe drug reactions? I don't know. You try it, Joe. Get back to us.
I know, yeah.
Okay.
Just for future reference next year.
All right. Well, thank you, Maria. So it was measles.
Yeah, it was.
Okay.
Yeah.
Awesome. Joe, how about we end off with some serious do not miss rashes?
Okay. So a 23-year-old male presents. He's got 2 days of headaches and fever. He's now presenting. He's got a reduced GCS, an ultimental state, widespread purpuric macules and patches. So flattened lesions between a centimetre and greater, and they're purpuric, so they're non-blanching rashes, and they're on his trunk and his limbs. Mm-hmm. What do you guys think about this?
Is this meningococcal disease?
It is. Yeah. Okay. Next one, an overweight 50-year-old male presents with 6 weeks. He started allopurinol for gout. He's now presenting with flu-like symptoms, fever, lymphadenopathy, and his rash is a diffuse erythematous rash made up of macules and papules, so maculopapular, with associated cheilitis and genital involvement. On investigation, there's LFT derangement and eosinophilia.
Is it dress because of the eosinophils?
It is, yeah.
Yeah.
So dress, we actually haven't covered it completely yet, but is a drug reaction with eosinophilia and systemic symptoms.
A good learning point there, just quickly while we're talking about dress, is the red flags for a scar or, as we said, a severe cutaneous adverse reaction. And that's pain rather than itch, fever, desquamation or blistering, mucous membrane involvement, lab abnormalities, so specifically eosinophilia, LFT derangement, and kidney involvement, so res creatinine, and lymphadenopathy. If you see any of those things in association with a maculopapular rash, you have to be thinking about scars.
Yeah, okay, that's useful.
Okay, why don't we do a couple more? A 50-year-old woman presents, she's got painful flaccid bullae, which initially she says developed inside her mouth and on her genitals, and have since spread to her trunk and her face. There's many of the lesions have ruptured and they've left behind slow healing, itchy and painful erosions. There's a few non-ruptured lesions left, and you go around as a brand new intern who wants to test this out, and you're able to pop them all so they're Nikolsky positive. Don't do that. But Jason, what do you think this is?
I think this is, because it's painful, and as you said, Nikolsky positive, I think we have to be thinking about pemphigus vulgaris.
Yeah, that's right. And if we just do one last one, so a 3-year-old child with 2 days of fever and irritability, right, is now presenting with a widespread, painful erythematous rash with fluid-filled bullae, particularly intertriginous, so areas of friction which rupture and peel off in large sheets.
Do I take this one?
Go for
If
it.
you know it.
Well, I mean, I don't. I just don't know if it's the large sheets thing. It's not a scalded skin syndrome, is it?
With one more S, yeah.
It's staph.
Staph, scalded skin syndrome. Yeah, well done.
I didn't actually know that one.
Nice, awesome, good job. Okay, Matt, so let's say you're sitting with your intern self here right now. Do you have any final tips that you'd give him for seeing rashes in the inpatient ward-based setting?
Yeah, I think the inpatient setting is really different to the outpatient setting, and I think the inpatient setting is a really good opportunity to learn. I mean, I'm definitely absolutely still learning, and most of the time when I go consult about a rash, I actually don't know what's going on until I've seen and really thought about it, probably discussed with a consultant. And so I think the first thing to know is that when you're calling me, for example, there's no expectation that you know exactly what's going on, right? But I think there is an expectation that you've had a hard think about what's going on. And unfortunately, that's what's missed in a busy public hospital where some rash is identified and then it's quickly called dermatology to sort it out. But I think what would be really helpful is if most people, maybe unlike some other specialties, kind of took a step back and just thought, what's actually happened to this person? Like, how did this happen, right? Was there some exposure of a contact or a drug, or, is there an infection? What is going on in this patient's skin that is driving this? And then what is the pattern? And like you've drilled pretty nicely in this podcast, kind of really trying to identify the morphology and what things look like, and just have a go at describing them. I'm really pleased and I kind of really reassured when people call me and they say, look, I don't know what's going on, but this is not maculopapular, this is a widespread scaly, annular, somewhat violaceous plaque, and it coalesces into a confluent area that is, I'm worried about X, Y, and Z. And have a think about what the pathology could be. I think if you've done that, you've obviously made my job a lot easier, but you've really used your kind of mental problem-solving skills to get half the diagnosis. And then from there, I think what else is really good, like we spoke about, is just to make sure you identify red flags, because oftentimes it is the intern or the resident that identifies the red flags because the patient has a million other problems, the hospital's kind of want you back to get them out here, but then the intern goes and has a look, actually, you know what, there is a blister in the upper thigh, what's going on here. And I think if you see that, it is really important to speak up and actually be aware of red flags. But the most important thing is have a go and really think about what's going on.
Mm-hmm. So basically having like a specific consult question.
Yeah, that's right. I think having a question is really helpful rather than they have a rash. I think, if the question is this a drug hypersensitivity and therefore is it going to evolve? I think that's a really good question. And, I'd like to think that most of us would be really kind of happy to help out and to think of that.
Yeah. Awesome. Thank you, Matt. That was really helpful. And thank you for being here. Thanks, Joe. Thanks, Maria. I think that's probably a good place to end off, unless anyone has any burning or itching dermatological questions. No?
The look of disappointment on Joe's face.
I do have one.
Yeah.
Oh, no.
Yeah. A 16-year-old boy presents to his school nurse with a singular, discrete flexure lesion in his left elbow, antecubital fossa. It's erythematous. It's got a blue outline and crossed hatch in blue as well. What do you think?
Cross hatching?
Yeah. What do you think is going on?
What's cross? I
I'm
don't
so
even
glad
know
you
what
asked
that is.
that. What is cross hatching?
Like, you can imagine
In
like
blue.
a sort of line.
Has he just
across
drawn on
it. Yeah.
himself?
Hey?
Has he drawn on himself as a text?
Paid
Correct.
Really?
That student was me. And when I went as well, the school nurse. And she spent 30 minutes staring at it and then lost her mind when she asked me, have you drawn on this?
Did you have to go home from school? Is that why you did it?
No, I did have some eczema and stuff, but I decided to draw on it because it helped with the itching.
You're a weird guy.
I can't believe I guessed that.
Yeah, that was pretty good. Well done.
Oh my God.
Bye-bye.
Thanks for listening.